All right, good afternoon once again. Good morning for those in the East Coast, and then almost good evening to our colleagues from Ethiopia. So my name is Dr. Chris Owu, from the lead from Ghana, and we want to welcome all of you to the Global Critical Care Fellows Seminar Series, a collaboration between the Johns Hopkins University Global Center for Emergency Care, the Kolebu Teaching Hospital, and the St. Paul's Seminar Millennium Hospital in Addis Ababa, Ethiopia, and for our fellows in Ghana, Ethiopia, and quite frequently joined by other fellows from other countries. Today, we're going to talk about clinical and evidence-based reviews of acute respiratory distress syndrome. And we are very, very privileged to have presenting for us today Dr. Erika Yu. Dr. Erika Yu is currently an associate professor of medicine and medical intensive care unit director at the Thomas Jefferson University Hospital in Philadelphia, where she has been on faculty in the Division of Pulmonology, Pulmonary Allergy, and Critical Care Medicine for nearly 7 years. Following Erika's completion of internal medicine residency at the Columbia in New York City and fellowship in PCCM at University of California in San Francisco, she started her career at Drexel University, where she also served as the Medical Intensive Care Unit Director for over 4 years before transitioning into the same role at the Jefferson. Dr. Yu is deeply involved in trainee education and is consistently included among the top 25 teachers honored yearly by the Internal Medicine House staff. She has also twice been the recipient of the Internal Medicine Residency Award for excellence in teaching in pulmonary and critical care. In addition to rounding clinically in the medical intensive care, Dr. Yu is passionate about understanding and optimizing how healthcare is delivered in the critical care setting. After focusing on research training during fellowship in ICU policy and health services, she sought additional education in the science of patient safety and quality in order to further her scholarly inquiry. Erika, you are welcome. Our fellows and attendants are happy to have you join us today, and we look forward to a very insightful presentation as we always do. Thank you very much.
Thank you so much. Thank you for the warm introduction, and thank you for having me today. I'm so excited to be here. And I recognize that a subject like ARDS is something that is very bread and butter critical care. But what I've certainly learned over the course of being a teacher to trainees over the years is that sometimes it's nice to hear the same thing in different ways. And then you absorb different types of information in different ways by learning it in different formats. So hopefully some of this content is illuminating, and I certainly hope that it's interesting to you. So let's see here. I have no disclosures. And as in any talk, we're going to start with a few objectives. So first is to review the evolution and definitions and diagnostic criteria for ARDS. I think it's really interesting to think about this historically and see how the definitions for ARDS have evolved over time in these various iterations. To understand the physiology and characteristics of ARDS clinical presentation, and certainly how ARDS in and of itself clinically evolves. And lastly, to summarize the evidence for ventilator strategies in ARDS. And I focus on ventilator strategies because I recognize there are so many different types of therapeutics, some of which are pharmacotherapeutic, some of this are simply positioning, but really what I'm going to focus on for the purpose of this talk are ventilator strategies in ARDS. So what is ARDS? And I think the most important take-home message that I find often a lot of the residents don't necessarily fully comprehend is that ARDS is not a disease, it is a syndrome. It doesn't have a straightforward trajectory of treatment and recovery, and it's also composed of a number of contributing risk factors, multifaceted means of diagnosis, and can be characterized by many clinical histories. But if we think about it from a clinical and pathologic perspective, what ARDS I always think of is wet lung. So it was first described as shock lung or wet lung years ago and was recognized as an entity in 1967 as ARDS. So there is some insult, whatever that may be, that causes acute diffuse inflammatory lung injury, causing leaky vessels in your lungs. Clinically, what we would see would be hypoxemia and bilateral radiographic opacities. And pathologically, what we see here on this slide, this is taken from a New England Journal of Medicine paper in 2000, is diffuse alveolar damage. So that is sort of like the buzzword in pathologic diagnosis of ARDS. You can see here like sort of the lining of the air sacs is ordinarily thickened, and these are the hyaline membranes that you see develop in the ARDS injured lung. So the first effort to quantify the severity of physiologic injury associated with ARDS was the lung injury score, or the Murray score. And John Murray, I had the honor of having him as actually one of my attendings when I was a fellow at UCSF. And at that time, he was sort of an emeritus, and he actually lived in Europe and would come back to the United States, to California, to attend for a week here and there. And so I did have the honor of knowing him and meeting him. Unfortunately, he died of COVID complications at the age of 92 in Paris. So, his legacy was to develop this Murray score in ARDS. And this is, as I said, one of the first efforts to quantify the severity of physiologic injury. And so there are 4 different variables that were used, and they had various point values that were assigned. And then based on these point values, you would calculate the score as the sum divided by the number of components. And you can see here, if you had 0, the score was 0, no lung injury. In this range of 1 to 2.5, mild to moderate lung injury, and then greater than 2.5 was considered to be severe lung injury. And every revision to the ARDS definition that has been made since then has been with the goal of not only consistently and accurately identifying patients with ARDS with similar characteristics in order to identify them for clinical care, but also to enable us to epidemiologically track them and also have them enrolled in clinical trials so that there can be some standardization of how we define them. So this was the first sort of severity quantification that was made, this lung injury score, Murray score. And this was followed up in 1994 by the American European Consensus Conference, where they came up with this definition. So you can see here, one of the distinctions compared to the Murray score that preceded it was the exclusion of PEEP. So if you remember just in the previous slide, we did actually have PEEP included in this definition. Now PEEP is not in the definition, and you'll see it come back again in a later iteration. And also they included this part here, no evidence of left atrial hypertension or a wedge less than 18. So there's a deliberate attempt to exclude cardiogenic pulmonary edema from the definition of ARDS. The other distinction here was the identification of this acute lung injury. This is no longer a term that's used, at least in the formal ARDS definition. And so basically had to do with severity of hypoxemia. And you'll find some of the older studies that look at ARDS actually make distinction, not necessarily between mild, moderate, severe ARDS, but just ARDS and ALI. And so acute lung injury was with P to F less than or equal to 300, and the ARDS was at P to F less than or equal to 200. And that was the older definition in the 1990s. This was followed up in 2012 by the Berlin definition, so-called because the consensus conference was held in Berlin. And they added a lot of specificity to the ARDS definition. You can see first here with the timing. Before we just called it acute. But now we have acute onset is respiratory symptoms that develop within 1 week of known clinical insult, or new or worsening symptoms in the last week. So we have some clarity to the term acute onset. For chest imaging, before we used to have just bilateral infiltrates, and that was what was included in the definition. Now we have bilateral opacities that are not explained by effusions, lobar, lung collapse, or nodules. So we characterize the lung infiltrates a little bit more. When it comes to the origin of edema, if you remember in the 1994 consensus conference definition, there is a pulmonary capillary wedge pressure cutoff. And so to keep with the times and understanding that a good number of times we don't have a Swan-Ganz catheter in place, the source of lung edema is identified as being respiratory failure not fully explained by cardiac failure or fluid overload, and you don't have a wedge cutoff. And then with oxygenation, we assign grades of severity, and these also include minimum PEEPs. So again, remember, we have the Murray score that had PEEP included in the definition. Then we had the AECC consensus conference that took PEEP away. Now you see PEEP coming back here. So you have us not only with grades of severity and a minimum PEEP criteria. So PEEP or CPAP greater than or equal to 5 centimeters of water. The other thing that was of value with this Berlin definition was that there's now associated predictivity for mortality. So this is what I have in parentheses here. Predicted mortality for patients with severe ARDS was as high as 45% in contrast to moderate or mild, which are generally on par with one another, about 30%. So again, this is tremendous value epidemiologically and also for the purposes of research evaluation. So if we to remember that Berlin definition and we look at this first X-ray here, the first question would be, is this radiography that's consistent with ARDS? And looking at this chest X-ray here, predominantly what you see, and I guess the arrows give it a little bit away, what we see mostly are pleural effusions. And therefore, if we go back to here, not bilateral opacity is not explained by effusions, lobar, lung collapse, or nodules. So because we have this increased specificity in describing what these infiltrates are, this would not qualify as ARDS radiography. Similarly here, this is very characteristic of right upper lobe atelectasis on an X-ray. It tends to pull up and in. You can see atelectasis of the right lower lobe with right upper lobe, with some degree of tracheal deviation. So again, if we were to answer this question, is this a bilateral? It is only unilateral here. It also is characteristic of atelectasis. So therefore, it would not be characteristics of ARDS radiography, even if they met other criteria clinically. But even since the Berlin definition in 2012, there have been significant changes in evidence and practice that contribute to changes in the definition. Firstly, we know that there is validation of pulse ox in lieu of serial arterial blood gases for evaluating oxygenation criteria. We know from the Florally trial in 2015, and from just our experiences with COVID, that there's increased utilization of high flow nasal oxygen to manage severe hypoxemic respiratory failure. So there is a population of ARDS that actually never gets intubated. There is a growing role for ultrasound in evaluating lung infiltrates. And I am old enough that ultrasound was actually not a huge part of my fellowship training. And since then, I always tell my fellows now that they are far better at ultrasound than I ever will be, because it has just become really standard of care in the critical care setting, not only for procedures, but also for evaluating lung infiltrates. So there's a recognized growing role of ultrasound in evaluating lung parenchymal disease. And then, of course, there's this acknowledgement of the recognition that we need to apply definitions to resource limited settings. So there are in instances where you don't have ready access to chest x-rays or blood gas machines, or not even sometimes where ventilators are not always available. This is considered to be what in the literature is called the Kigali modification. And we have to apply our ARDS definition to those resource limited settings as well. This is just an example of B-lines that you might see in an ARDS patient on ultrasounds. You see the pleural interface here and these shimmering lines that are just emanating down from the pleural interface. And these are what you would potentially see when, if you were to put your probe on the chest of a patient with ARDS. So these B-lines would be characteristic. And these recognitions culminated in the most recent definition, which is considered to be the global definition of ARDS. And this is not meant for you to be able to read this entire section here. Obviously, it's readily available in the reference that I have provided here. But the committee for this global definition made 4 main recommendations. One, as I mentioned, was the inclusion of high flow nasal oxygen at a rate, a minimum flow rate of greater than or equal to 30 liters per minute. So the inclusion of, again, non-intubated ARDS as a patient population that previously we would have potentially missed. Not only the use of P to F ratio, so we think about from the Berlin definition, the mild, moderate, severe, less than 300, less than 200, or less than or equal to 100. But also the recognition that in patients with SATs less than 97%, you could use pulse oximetry and use S to F ratios. So pulse ox S to F greater less than or equal to 315, as long as the SAT was less than 97%. Obviously, that has to do with the oxygen hemoglobin dissociation curve to identify severity of hypoxemia. So that was a second recommendation. Third recommendation was the retention of the bilateral opacities on chest radiograph or CT as the imaging criteria, but the addition of ultrasound. So the bilateral B lines and our consolidations by ultrasound, again, not fully explained by these exclusions, effusions, atelectasis, or nodules or masses. So again, we're giving another potentially chest imaging modality that can be used for diagnostic criteria. And lastly, the modified part, the fourth recommendation is the modified definition for resource variable settings. You don't necessarily require PEEP, oxygen flow rate, or specific respiratory device support devices in order to meet criteria for the ARDS. So it gives you a little more flexibility in assigning this definition, this clinical definition of ARDS. So that was a little bit of a short historical tour of how the definition of ARDS has evolved, again, not only for epidemiological purposes, but also for research purposes to help us really be able to understand this heterogeneous disease. So I'll move on to the next subject in this talk, which is the epidemiology. So this, I think a lot of people are aware of this today. This is the Lung Safe trial. This was a cohort of, I believe, 440 of patients taken from 459 ICUs from 50 countries in the period prevalence of a 4-week period in the winter of 2014. And they really sought to just define the epidemiology of ARDS at the time. So we can see here that ARDS comprises about 10% of ICU admissions and about nearly a quarter of patients on mechanical ventilation. The period prevalence within this 4-week period in 2014 and with the severity was 30% of the cases that were mild, nearly half were moderate, and about a quarter of them were severe. And the other thing that was rather telling was that in terms of our ability to clinically recognize ARDS, we were able to recognize severe ARDS more easily than mild, for example, and as many as half of mild ARDS cases were missed clinically by clinicians. And so I think this under recognition of ARDS, especially when in its less severe state, may stem from the considerable clinical heterogeneity observed among the patients who meet ARDS criteria. And so I think that's a really sobering thought to think that we do miss up to half of patients with mild ARDS, and that can certainly have therapeutic impact in our decisions and on the patients and clinical impact on the patient's outcomes. So we'll go back to this statement here that ARDS is a syndrome, not a disease. There's tremendous heterogeneity of cause or risk factor. There's tremendous heterogeneity of clinical presentation. And what we learned from certainly the COVID pandemic was the onset of ARDS maybe a little more indolent than originally thought. Though we do consider, again, per definition, that hopefully the injury is within a week. The acute insult is within the week with the development of lung injury. There's tremendous heterogeneity of radiology, and I'll show you some examples of that in the following slides. And of course, there's heterogeneity of disease course and recovery. And it's because of this wide range of triggers, this broad definition, and the variable outcomes with ARDS, that there's relative paucity of practice-changing discoveries can really impact outcomes. And I'll go through that in a little bit more in the management section of this talk. But really, like in terms of just the game-changing interventions that truly save lives in ARDS, there's a relative paucity of those. And this is probably because of the heterogeneity of the syndrome in and of itself. So here, tabulated, you can see just a list of potential causes of ARDS. And I'm sure that you're well familiar with these, the direct causes such as pneumonia, aspiration. These again would be direct injury to the lung versus indirect injury, like non-pulmonary sepsis, which is actually one of the most common causes of ARDS. Pancreatitis, drug overdose, trauma, etc. There are less common precipitants like smoke inhalation or drowning, e-cigarette use, multiple transfusions. And then, of course, these are the diagnoses that are not typically classified as ARDS listed here: DAH, pneumonitis from drugs, organizing pneumonia, etc. So this table is really just meant to bring home the fact that there is tremendous heterogeneity of cause associated with this clinical syndrome. And here are some examples of just the radiographic heterogeneity and that may contribute to our ability as clinicians to diagnose ARDS or recognize it, especially in its less severe cases. So this first X-ray here, this is one of the sort of no-brainer kind of X-rays where it looks terrible, right? There's diffuse bilateral stuff on both sides here, and this would be what, you know, a lot of trainees would say, white out of the lung, you know, both sides. It's just, you have some aeration, but there's certainly a lot of just parenchymal injury here. And this would be probably one of those situations where if the patient was severely hypoxemic and met all other criteria, it would be relatively easy to say this patient has ARDS if we were to look at this radiography. However, this is another example of ARDS radiology. Again, if the patient meets all the other clinical criteria, severity of hypoxemia, timing of injury, exclusion of cardiogenic pulmonary edema, etc., this could also qualify as ARDS. And even something as subtle as this, right? And these little arrows are marking here, just some bibasilar infiltrates, atelectasis, whatever you may want to call this, again, understanding the sensitivity of X-rays. This, in the appropriate patient who met the criteria clinically, this could also qualify as ARDS. And you can see here just tremendous radiographic heterogeneity, even in these three X-rays, in terms of patients who could meet ARDS criteria clinically and have such a widely disparate radiographic changes. And because of this heterogeneity, there have been considerable efforts to phenotype ARDS and help us to understand this heterogeneous syndrome. Many of the clinical variations of ARDS may actually be reflective of underlying biological differences between ARDS patients that are now recognized as important drivers of treatment response and certainly ultimate outcomes. So in the past, there have been certainly evident efforts to phenotype ARDS clinically by severity. An example of this would be the Berlin criteria, where we had mild, moderate, severe ARDS and the associated mortality with each of those various degrees of severity. There's also been efforts to clinically phenotype ARDS by cause. So for instance, something like sepsis-associated ARDS is traditionally associated with worse outcomes than something like trauma-associated ARDS, which tends to have a better prognosis and biologically has actually been found to have less severe endothelial and epithelial injury associated pathologically. Already mentioned phenotyping ARDS by type of injury, so direct versus indirect, so direct lung injury versus indirect lung injury. And there is some suggestion that direct lung injury may be less PEEP responsive and actually have worse outcomes than indirect. And lastly, by timing of onset. So clinically early onset, for example, within the first 48 hours, may have a different prognosis than later onset ARDS. But sometimes, and we all know this clinically, the timing of onset can be really difficult to elucidate. There also have been efforts to phenotype ARDS radiologically. So there's the non-focal or diffuse ARDS versus the focal or lobar ARDS. And I'll show you an example of that in the next slide here. So here is an example of focal ARDS here and diffuse ARDS. And the diffuse phenotype has been associated with actually a higher mortality, lower lung compliance, and more commonly is secondary to indirect lung injury. The diffuse ARDS also tends to be more PEEP responsive, whereas in the focal ARDS here, we sort of have more of these bibasilar consolidations, maybe a little bit of adjacent effusion here. When you augment PEEP, you may have significant overdistension of the good lung without actually true recruitment of the bad lung. So again, phenotyping ARDS, however this may be sought to be done, can actually contribute considerably to our understanding of treatment response and outcome. So taking this one step further is this concept of subphenotyping ARDS. And so this is very much aligned with this concept of precision medicine. So this is really the direction in which clinical care for ARDS is going. And in this particular study, they took all the NHLBI, so National Heart and Lung Blood Institute ARDS studies, and they sort of pulled all those patients together. And they conducted something called latent class analysis, which is really just an approach to identifying subgroups within a heterogeneous population. And they identified two specific subphenotypes, the hypoinflammatory subphenotype and the hyperinflammatory subphenotype, using all the pooled data from these previous ARDS studies. And what they found was that there was actually significant differences in biology, outcomes, and treatment response. And this enabled some degree of prognostic enrichment. So again, contributes more to our understanding of this heterogeneous syndrome and the patients who are affected by it. And what they found was that the hyperinflammatory subphenotype of ARDS among all these studies had significantly higher 90-day mortality. They had more shock, they had higher circulating plasma inflammatory biomarkers, and were at higher risk of death. And this is really, as I mentioned, the direction which ARDS management is going in an attempt to just help us more readily understand why certain patients with ARDS do better than others, and why do certain patients respond better to the therapeutics that we have available. So just in a different format, the hypoinflammatory and hyperinflammatory subphenotypes are associated with different biomarkers and outcomes. So you can see here the hypoinflammatory subphenotype has lower levels of circulating inflammatory cytokines, associated with lower mortality, more ventilator-free days. In contrast, this hyperinflammatory subphenotype has high levels of these circulating cytokines, IL-6, IL-8, TNF, protein C, and has associated higher mortality and reduced ventilator-free days. So understanding, being able to characterize patients as hypo or hyperinflammatory will contribute to a prognostic understanding as well. So we'll take a step back and just go into a little bit of pathophysiology. And again, understanding this is something that likely you are well aware of, but this is one of those very recognizable diagrams that we've all seen before. And this is the normal alveolus. And there are two separate membranes that form the alveolar capillary membrane. So the alveolar epithelium here and the microvascular endothelium. And basically in response to whatever injury that may happen to the alveolus during the acute phase, it causes a tremendous amount of inflammation. And you have a ton of pro-inflammatory cytokines and disruption in both of those barriers that causes fluid to accumulate in the lung, proteinaceous fluid to accumulate in the lung. So clinically, how does this manifest? Well, first you would have various phases of the ARDS. First would be the exudative phase. So this is sort of this acute phase, and lots of lung water, very hypoxemic patients, but really occurs 2 to 4 days after the onset of lung injury. Second would be the fibrosing alveolitis, the fibroproliferative phase of ARDS. And lastly would be the recovery phase. And this can be rather extended. There can be continued improvement as long as 6 to 12 months or even longer. And I'll show you some examples from literature of patients one who did improve and one who didn't. And so I think sometimes it's who's going to improve and actually have true recovery can be a little bit hard to predict. And these distinct phases of ARDS are characterized by different clinical, histopathological, and radiographic manifestations. So here we have an example of the exudative phase in ARDS. So you can see here on diffuse bilateral parenchymal infiltrates here on X-ray. Again, a lot of diffuse ground glass, some dependent effusions here, certainly. And in this accumulation in the air spaces of just fluid, protein, and a lot of inflammatory cells. And this is radiographically what you may see in a patient who's in the acute exudative phase of ARDS. The second phase would be the fibrosing alveolitis, or the fibroproliferative phase of ARDS, characterized clinically by persistent hypoxemia. This is just a lung cyst here. I don't want you to be thrown by this, but in addition to that, increased dead space due to poorly perfused alveoli. So these alveoli are ventilated in the absence of perfusion, and that can be anatomic or pathologic, but it's certainly pathologic in a disease state such as ARDS. You have proliferation of connective tissues and other structural elements of the lung that result in worsening lung compliance. And largely you have partial resolution of actually the lung water or the pulmonary edema phase of the ARDS. And now you're starting to get the stiffer lungs as a result of this worsening compliance in the fibroproliferative phase. In recovery, as I mentioned, if it occurs, can be quite prolonged. The lung can reorganize and recover. And there can be differing levels of recovery depending on the individual. But what you would see would be resolution of the hypoxemia, improved lung compliance, and radiographic abnormalities can resolve completely. So here's an example taken from a radiologic journal of a 25-year-old ARDS survivor. This first CT is from the phase of acute illness. We have a lot of dependent consolidation, so non-dependent ground glass. And then 8 months later, there was another CT scan. You can see that a lot of that disease has largely resolved. Maybe there's some residual anterior reticulation here and here, but largely this 25-year-old ARDS survivor has fared quite well in terms of recovery. In contrast, here's an example of a 54-year-old COVID ARDS survivor, and you can see the dramatic difference. This initial scan here, which was about 2 weeks after admission, already shows some evidence of potential traction, so some pulling, some scarring with some pulling dilatation of the airways. A lot of ground glass here, which is largely resolved in the second scan, which is from 6 months afterwards. But here now you have fibrotic disease, right? You have a lot of architectural distortion, traction, and in this particular patient clinically, in contrast to the previous patient, had a lot of persistent residual symptoms and lung function abnormalities. So again, who recovers can be difficult to predict, but I think this is where subphenotyping ARDS patients may come into play and give us a better understanding of, again, not only treatment response, but also outcomes. So moving on to the last section of the talk was management strategies in ARDS. And I list a host of them here. And again, I'm not going to go over all of them because I will be focusing largely on ventilator strategies rather than pharmacologic strategies or more invasive supports like ECMO. But I thought this was a nice graphic taken from this Critical Care Journal in 2023 that really separated out in the green here treatments that we know improve outcomes that are supported by prospective RCTs. So we know that low tidal volume ventilation, prone positioning, conservative fluid management have evidence that improves ARDS outcomes versus the orange section here, where we have treatment that may improve outcomes based on retrospective data. And I'll go a little more into driving pressure in the subsequent slides. Gray shows some pharmacologic interventions that may improve oxygenation, but thus far have had no evidence of improving actual patient outcomes, no sustained clinical benefits. So inhaled pulmonary vasodilators include things like inhaled epoprostenol or nitric oxide and neuromuscular blockade. And lastly, here in the purple, treatments that likely derive benefit in a subset of patients. So again, this concept of precision medicine, there are patients in whom these things may work. But I think certainly the overlaying evidence doesn't apply to all comers and patients. And moving forward, I'll focus a little more on the ventilator specific strategies in ARDS. So the first and obvious, the most important would be the low tidal volume ventilation. This is the ARMA trial, the low tidal volume management, low stretch modality of treating patients with ARDS. And this is taken, and the premise of this is that there are structural and functional alterations in the injured lung from the vent in and of itself. And I always say it's very unfortunate. Oftentimes the mainstay of therapy, the main intervention that we do for patients who are severely hypoxemic is to put them on an invasive mechanical ventilation. But the vent in and of itself injures the lung. And this is the concept of ventilator-induced lung injury. So there's trauma from, it's very unnatural, right? We don't breathe positive pressure breathing. And so this very unnatural way of breathing, which is the mainstay of therapy for patients who need respiratory support, directly injures the lung in and of itself. So there's the concept of volume trauma. So the actual tidal volumes that are being delivered. Barotrauma would be pressure trauma. And atelectic trauma would be referring to the repetitive opening and closing of the small airways and alveolar units. And all of those things together can actually structurally and functionally alter a lung that is already injured. And so the goal with lung protective low tidal volume ventilation would be to reduce this injurious lung stretch, and thereby reducing the release of these inflammatory mediators as well. So this is the study that we all know. This is a study that 25 years later still remains the mainstay of therapy for ARDS with proven mortality benefit. And this is the ARMA trial. So this was conducted at 10 university centers between the years of 96 and 99. It was a randomized trial, and patients were randomized to 6 cc's per kilo tidal volume versus 12, of course, seeming astronomically high, of a predicted body weight. And patients had weekly follow-up for 180 days after. And the tenets of this strategy were that we tolerated high CO2s. We had goal plateau, which is again the static measure of lung compliance, or surrogate static measure of lung compliance, of less than 30 centimeters of water. Our goal PO2 was not shooting for normal, right? We're not shooting for normal here. We're just shooting for acceptable. So PO2 in the range of 55 to 80. And the addition of bicarb for pH is less than 7.15. And these were the management tenets used in this protocol. And this is just an example here of the lower PEEP, higher FI. This was all very, the RTs were sort of on autopilot following these tabulated lower PEEP, high FiO2 protocol. And this is something that I always try to point out to the trainees, certainly when I'm on rounds, and this is still accessible online. You can download this pocket card, and you can actually fold it into fourths and carry it around. And you can follow exactly what the ARDS mechanical ventilation protocol was. And they list the inclusion criteria, ventilator setup and adjustment. You could pick the high PEEP or low PEEP table. When I was actually a fellow in San Francisco, this was on paper orders. We'd actually circle which table we wanted the RT to follow, and then the patient would just sort of go on autopilot and titration. We see plateau pressure goals here, what to do when the plateau pressure was in excess of what was wanted. And this goes so far as to not only manage the acidosis management, also takes you into the weaning. So I thought this was a great resource. I often recommend the residents can print it and actually refer to it so they can see exactly what the protocol was when this trial was conducted. And why was this such a game-changing study, and why does this hold true 25 years later? Well, ARMA yielded a reduction in hospital mortality from 40% in the group of patients who were receiving traditional tidal volumes to 31%. So there was a tremendous reduction in mortality, improved survival. So low tidal volume ventilation in ARDS saved lives. And this is the reason why, and you'll find in a lot of ICU studies, we like the things that save lives. And because they're so few and far between, and it's tremendously difficult to save a life in the ICU. And so this is why this was such a game-changing and powerful study that still holds true so many years later. So again, moving on to another ventilator strategy is this concept of open lung ventilation. And what this refers to really is higher PEEP strategies and entities called recruitment maneuvers. And I'll go a little more into the evidence in support or not in support of these strategies. This is an example, again, taken from that ARDS pocket card of the higher PEEP, lower FiO2 protocol. You can see here how PEEP was titrated to a max of as high as 24 if patients were on this pathway. So what do we know about higher PEEP strategies? Well, there were 3 large RCTs that have been conducted looking at higher PEEP, exploring the impact of higher PEEP on ARDS outcomes. These are the 3, Alveoli, LOVE, which was the lung open ventilation trial, and the EXPRESS trial. 2 of these were actually in the same issue of JAMA, right next to each other. And they were consistent in that higher PEEP didn't necessarily cause clinical harm, but it did not necessarily save lives. And so I think in practice, what that results is, and this certainly is, there are populations in whom higher PEEP may be more effective. And this is in meta-analysis, what was done here. This is a little confusing because this was back in the day when this is the ALI population. So this would be more not without ARDS, but more mild, moderate versus mild versus moderate to severe. So in patients with ARDS or moderate to severe ARDS with P to F less than 200, there may be a subpopulation of ARDS patients who are more severely hypoxemic, in whom higher PEEP can actually have the potential to show improved mortality. So again, this goes back to this concept of phenotyping, subphenotyping ARDS. Though the bulk of evidence in RCT trials looking at higher PEEP don't show a mortality benefit, if we were to focus on a subset of patients with more severe ARDS, are these the patients in whom higher PEEP strategies can actually improve outcomes? And I think this is something that will continue to be studied in years to come. The second concept of sort of more lung open ventilation is recruitment maneuvers. And this is the main recruitment maneuver randomized controlled trial that was conducted. This was the ART, alveolar recruitment for ARDS trial. And they had a very strict protocol that was followed in this study. They provided a bolus paralytic, incremental PEEP increases in a population of over 1,000 moderate to severe ARDS in 120 ICUs across 9 countries. And as I mentioned, the patients were randomized to this very protocolized form of paralytic recruitment, incremental PEEP increases, titrated specifically to lung compliance versus a lower PEEP protocol. And what they found in their primary outcome of 28-day mortality was that patients in whom recruitment maneuvers were conducted had higher rates of 28-day all-cause mortality. They also saw in another secondary outcome of 6-month mortality that patients who received recruitment maneuvers also had a tendency to have higher 6-month mortality as well. So I think the bulk of evidence in some shows that recruitment maneuvers can have the potential to cause harm. And if they are done, I would say certainly in contemporary practice, they are done with not that typical 40 for 40, which is always a little bit fair, 40 centimeters of water for 40 seconds, but in more temperate or moderate ways, in an effort to distend hopefully the good areas of the lung and help them contribute to improved gas exchange. But I think if you were to look at the evidence, certainly there is no good evidence to support standard recruitment maneuvers in the care of patients with ARDS. Driving pressure is something that I think a lot of people pay attention to, and this is taken from this one New England Journal of Medicine retrospective study that was published in 2015. And what driving pressure essentially reflects is the pressure required to distend the lungs, and its primary function is to overcome the elastic forces to the pulmonary system. It is linked to ventilator-induced lung injury, and most studies have scaled tidal volume to predicted body weight to scale to the lung size. However, in ARDS, the proportion of lung that is available for ventilation is decreased. And this refers to this concept of the baby lung. And I'll show you a little more about that in the next slide. And it's reflected in low compliance. So here is the pictorial representation of what's thought to be Gatinoni's baby lung. So the pathoanatomy of ARDS is that in addition to being a very clinically heterogeneous disease, is very heterogeneous when you're looking at it radiographically. So there are very inhomogeneous distributions of injured lung and not injured lung. And so there are areas that are completely, totally deprived of oxygenation and regions that are almost normally aerated. And what Gatinoni noticed in when he published this concept of baby lung was that the aerated lung tissue was about estimated to be this dimension similar to that of a 5 or 6-year-old child. So there was this concept of baby lung. And therefore his thought was that the ARDS lung is not necessarily stiff, but actually functionally small. And as a result, this concept of normalizing tidal volume to compliance as secondary to this concept of baby lung, and using this ratio as an index of the functional size of the lung, it can be better predictive of outcomes. Again, this is a retrospective pooled data study. What they found, driving pressure, easily calculated at the bedside as plateau minus PEEP, is a better predictor of mortality than compliance or tidal volume. And I think you'll see in practice, certainly at the bedside, again, that a lot of people will target driving pressures less than 15 centimeters of water. This, again, is more correlation and not causation, just simply because this is a retrospective observational study compiled from 9 randomized controlled trials studying ARDS patients. That said, I do think that it has value in bedside practice. I'll say a few words about alternative modes of ventilation. simply because, as I said, we're trying to focus on ventilator strategies in ARDS. The first would be something called airway pressure release ventilation, APRV, which is much akin to inverse ratio ventilation in that the I time is prolonged. So what you would set in an airway pressure release ventilation is the P high, a high pressure, high time, a duration of time that you stay at this high pressure, and a lower airway pressure, which is P low, and often set at 0, but you stay at that 0 for a very short period of time. And just another form of inversing the I to E ratio, and much of the spontaneous breathing is conducted at that high level. It is just considered to be one of those salvage modes of ventilation. I have found that in practice, there are certain institutions that are really good at APRV. The RTs are very comfortable with it. And there are certain institutions where the mainstay tends to be just more ARDS settings. And I find that a lot of times this clinicians using APRV has a lot to do with how comfortable you are with just understanding modalities. The best way I can remember of understanding the pitfalls of something like APRV would be that you though you can increase mean airway pressure and therefore increase the time for gas exchange, there is less control over tidal volume and less control over minute ventilation. And so one of these ways I've always remembered this is that APRV can cause auto PEEP and tidal volume creep. So you can't control the tidal volume as well. You can't control the CO2 minute ventilation. And so you may actually have auto PEEP and tidal volume creep as a result. I'll say a few words about oscillation, not necessarily because I'm an expert in oscillation. I think I have oscillated one person, I think, in my entire career. There's great evidence for this in babies, infants, neonates. And I'll show you the one big study that shows why we don't use this so readily in adults. But basically, you are titrating to a wiggle, a hertz in a patient. And so there's oscillatory gas that flows within the airways, these very small gas volumes that move toward and away from the patient. And then the flow actually oscillates at a very consistent mean airway pressure because of these low tidal volumes. And so this is basically just the epitome of low tidal volume, low stretch ventilation. So you have these gas flows, very super physiologic respiratory rates, and very, very low tidal volumes. And you set this mean airway pressure so that lung inflation is constant. So you don't have this repetitive opening, closing, this atelectotrauma of the distal airways and the air spaces, and really reduces the traumatic inflate-deflate cycle of traditional mechanical ventilation. I've heard high flow oscillatory ventilation referred to as just like a vibrating CPAP machine is maybe an easy way to think of it. But the reason this is, again, our practice is evidence-based, and we try to understand why we do certain things and perhaps not do certain things in the context of available evidence. This study came out in 2013, was a multi-center randomized trial, the OSCILLATE trial, conducted in 39 ICUs in 5 countries. And the intervention was high frequency oscillatory ventilation versus conventional sort of ARDS-NET, low tidal volume, high PEEP strategy. The population was, again, moderate to severe ARDS. And you can see here, looking at the outcomes of death in the hospital, death in the intensive care unit, and death before day 28. They actually halted this study early, so it was prematurely closed after they only randomized less than half of the planned 1,200 patients that they were planning to randomize due to the potential to cause harm. So you can see here, increased death in hospital, death in the ICU, death before day 28 in patients undergoing oscillation. And for this reason, you will find that oscillation is not conducted readily, but I do know that moving forward, we're again looking for that population in whom oscillation may be effective. Again, so phenotyping, subphenotyping ARDS in the same way that higher PEEP strategies may be more effective in improving outcomes in a certain subset of ARDS patients. There may be efforts moving forward, and I would not be surprised if this would be continued to be looked at in different subsets of ARDS populations to see if there is a potential benefit that exists in improving outcomes. So I recognized I covered a great deal of information, and I was hoping to, I think I managed to stay within the budgeted time, but here is in summary, ARDS is a heterogeneous syndrome with a high associated mortality. And if you remember from the lung safe trial, as much as 45% of severe ARDS patients will still die. So I think this is something that is very sobering for us as clinicians in terms of our ability to actually contribute to improving outcomes in the ICU setting. Understanding these ARDS phenotypes and subphenotypes through latent class analysis may help to elucidate the clinical and biological heterogeneity among ARDS patients, and also, as a consequence, help us to understand corresponding differences in outcomes and treatment responses. I think it's important for us to realize that, at least in randomized controlled trial form, the only method of mechanical ventilation that has been proven to improve mortality is low tidal volume ventilation. So that ARMA trial from 2000, New England Journal of Medicine, the low tidal volume ventilation strategy in ARDS is the only method on the ventilator that has been proven to save lives in moderate to severe ARDS. And lastly, I think this goes without saying, and this is often, again, very humbling for me as an ICU practitioner, is the recognition that supportive care, that's largely what we provide in the ICU. Supportive therapies, hopeful treatment of whatever the underlying cause may be, are the mainstays of treatment for ARDS. And I was asked to provide some questions, which I'm happy to go through next. Some knowledge check questions. So I'm not trying to think of the best way for these to be answered, but I'll read through the question. Perhaps you can just sort of think through the answers in your head here. Which of the following is not included in the most contemporary diagnostic criteria for ARDS? And if you could just harken back to the beginning of my talk, and just going through the historical context of ARDS definitions, we had the lung injury score, or the Murray score, followed by the 1994 AEC consensus conference, then the Berlin criteria, and then the global definition of ARDS in 2024. Which of the following is not included in the most contemporary diagnostic criteria for ARDS? So we have P to F ratio, S to F ratio, the wedge, bilateral opacities, or B lines on lung ultrasound. I think that we know that hopefully that you've taken away from my talk as well, is that certainly wedge pressure was taken out of the ARDS definition many years ago, and is really what we think about now is just excluding cardiogenic pulmonary to the best of our ability, and or fluid overload in order to assign the ARDS definition. Second question here would be, which of the following is a cause or risk factor for ARDS? We have various options here: non-pulmonary sepsis, trauma, pneumonia, pancreatitis. And I think if you were to, again, remember back that one slide where I had that table, again, listing all the potential myriad of causes or risk factors for ARDS, I think we could easily answer that all of the above. All of these things can cause ARDS, and the cause may have some contributory, provide some contributory understanding to prognosis as well. Third question I had here is, which of the following is not identified as a distinct phase of ARDS? So we have listed here 4 options: the exudative phase, the hypoinflammatory phase, the fibroproliferative phase or fibrosing alveolitis, and the recovery phase. So if we remember, again, when we went through sort of the clinical presentation and evolution of ARDS, we remember that there was an exudative phase early on, characterized by sort of diffuse bilateral infiltrates, severe hypoxemia. We had the fibroproliferative phase, when the lungs perhaps became stiffer and you had a little bit of reorganization in connective tissue, structural changes in the lung. And lastly, we discussed also the recovery phase of ARDS. And what we remember is that hypoinflammatory is not a phase of ARDS, is actually considered to be a subphenotype of ARDS. And again, this is the future of precision medicine, where we're trying to understand the hyper versus the hypoinflammatory phases of ARDS, associated differences in outcomes, and associated differences in treatment response. And then this is, I believe, the last question that I wanted to include here, is, which of the following ventilator strategies confers a mortality benefit in ARDS. And as you may recall throughout this talk, I did not necessarily focus on pharmacologic therapies like inhaled vasodilators or steroids. I didn't, this is like a whole body of literature. I think that is a separate subject. I did not review the PROCEIVA trial, which would be the proning, obviously the proning trial that really dictated much of what we did during the COVID pandemic, but really focused on ventilator strategies in ARDS. Some of which were beneficial and some of which were not, at least based on the available evidence. So which of the following ventilator strategies confers a mortality benefit in ARDS? So we have high frequency oscillatory ventilation. You recall that was the 2013 OSCILLATE trial. The higher PEEP strategies, we have the alveoli, the LOVE trial, and the EXPRESS trial. That was the main, those are the three main RCTs for high PEEP strategies. Recruitment maneuvers, that was the ART trial, the alveolar recruitment trial. And lastly, low tidal volume ventilation or lung protective ventilation. And I hope that, again, this is very easily answered based on the evidence that I have reviewed, is that the only ventilator strategy in existence that actually confers a mortality benefit and actually saves lives in patients with ARDS is the low tidal volume ventilation or the lung protective ventilation from the ARMA trial. So here is my contact information. I welcome any additional questions, or if you just want to reach out for whatever reason, here's my email at Jefferson, and I look forward to hearing from you all. And again, thank you so much for the opportunity to speak here today. And I hope that it was illuminating in some way and really gave you a little bit, not only of the historical context for ARDS in terms of how we define it and why we try to redefine it over time, but also give you some sense of future directions, and also summarize as thoroughly as possible in the limited amount of time some of the therapeutic choices that we may make in ARDS management. And that is all I have. So I think I will load the chat here and see if there were any additional questions, mostly answers to the questions, which I'm sure everyone has. Yes, naturally, everyone has gotten correct. But I'm happy to take any questions if there are any. And again, thank you so much for having me.